Like a lawnmower, steadily going down across the
How are you doing, guys? Doing okay? Hey, thank you all for coming out today. I really appreciate it. This is a great looking crowd. Wow. So thank you guys so much for being here. I know it's taking time out of your day, and but this is gonna be a great educational experience for you guys. And I'm just really grateful to have all of you here. So thank you so much for that. I want to introduce myself real quick. My name is Chris Chan. I'm the owner of Chelsea Place Senior Care. And we have an assisted living facility. We're in our senior daycare center now, and we also have a home care agency. And so those are some of the services that we provide, but that's not why you guys are here today. Why you're here today is to help, we're here to help educate you guys on being proactive, help understanding what is Alzheimer's disease, what is dementia, what's the difference between the two, Parkinson's. We got a lot of great experts, some fantastic speakers today. So I know we have a lot of information to cover, but I just want to just encourage you guys to ask questions, take notes. If you have any questions at our lunch break, let us know. If you need anything in regards to assistance with bathrooms, waters, anything like that, just make sure you reach out to Debbie back here in the green shirt, or Amanda. So anyone in this colored shirt here, we're here to help you guys. Okay. We'll make sure that we can, we'll get whatever you guys need. So, what I want to do first is explain what this event's about and where we're going as far as the next two series, because this is a part one of a three-part series. Today we're talking about raising the issues, being proactive. Next Saturday, same time, same place, we're going to be going over organizing legal affairs, making a financial plan. And then on the 27th of April, we're going to talk about how to find the right senior care and what is available to you guys. And what this process was we wanted to take this booklet that we created, which was Florida's 5-Step Guide to Senior Care, and bring that booklet to life in a live event. And so that's what this event's all about, is to create, is to help walk people through these steps, help them understand what options they have, and bring all that information that might be in this booklet and bring some more depth to it in a live event format. So in doing that, we also partnered with a great partner, which is Seniors Blue Book. I don't know if you're familiar with Seniors Blue Book. Is a directory of all the services that you will ever need for senior care, caring for a loved one, or just even being proactive about what's available to for myself. So we think it's a great marriage with our 5-Step Guide and their Blue Book, and it's a great partnership. We can help you guys walk through the steps. They're able to help you guys find the resources in your area. And that being said, I just want to introduce Amanda real quick. So Amanda's with Seniors Blue Book, and she's one of the folks that helped us put this event together. So just want to introduce her real quick. Here you go, Amanda.
Thank you. How many people here are familiar with Seniors Blue Book? Oh, that makes my heart happy. Thank you guys. How many of you actually know how to use it? Okay, fantastic. So you're all going to get a copy of this, and the reason I like to stand up and say that is when you're in a crisis situation, you are not thinking clearly sometimes, so you don't really know how to use this at that time. So I want to make sure being proactive about it and that you're familiar with it. The first half of the book is an A through Z guide of resources. This is doctors, hospitals, audiologists, ophthalmologists, and etc. The back half of the book is your grids, and I actually had someone ask a question about finding a Medicaid facility. For example, if you look back in the grids, which are at the back of the book, you can actually compare home care, home health, and housing options apples to apples. So it's really a fantastic Reader's Digest style size book for you to be able to find that. And I love to talk about what I do, clearly. So if you have questions, my information is in the publisher's letter, and I'd be happy to talk your ear off about Seniors Blue Book. Thank you.
Thank you, Amanda. And I got to introduce a very special guest today. When we first started our assisted living facility 8 years ago, I took one of my residents to Dr. Ruano's office. And I don't know if you remember this story or not, but he was one of the few doctors I had found that he took the time with me. He was just in the moment, talking through some of these issues. He was really interested in learning about what I was doing and what was going on with our resident. And it was one of the few doctors that are out there that truly care about their patient. And I was just so humbled and honored to have connected with him that day. And today he's going to share with you guys some very important information on how UTIs affect dementia or other things in the elderly. So that being said, Dr. Ruano, thank you so much for being here.
Good morning. Good morning. All right. First thing first, I'm a certified internal medicine physician from the American Board of Internal Medicine. I also have that little thing there, CMD, Certified Medical Director.
They can't hear
Can
you
you?
in the back.
Better? Okay. All right. Just wanted to let you know who I am. I do basically office care and what we call post-acute care. What is post-acute care? Years ago, my training was in a hospital. I did hospital care, and we did follow up on the community, on a clinic. I moved to Port Charlotte. Excuse me. I moved to Port Charlotte basically because I wanted to work with second generation people. I call it that way. I was debating if I should put there the elderly, the geriatric, or Charlotte. And why is that so important to me? Well, as you can tell, I wasn't born in America, and we have a very small family, and my mother has dementia. Just sharing that with you guys at fairly early age, in the 60s. And then I realized that between me and my brother, we're gonna have a very difficult time taking care of my mother and our families. Then since day one I started in my post-acute care training, I focus a lot on older people. I trained in Cincinnati, Ohio. We had a community hospital that was on the outside of the city limits, and we have a lot of retirees at that time. That was my chance. That was not really on purpose. But moving down here was on purpose, because that's what I wanted to do, and what best place. At the time where I made that decision, this was the #1 retirement community in the country. That was prior to Hurricane Charlie. Anybody remember that? Oh yeah. Okay. Then I know I don't have any financial ties with Chelsea Place. They don't pay me. This is all free. And you can ask any questions. You can interrupt me at any time. I have some of my patients here today. I'm not gonna even look at them because I don't want you to know who they are. But why are we picking this specific topic? Anybody have any idea why we picked that? That can kill you. Straightforward. It's one of the most common, if not the most common disease, infectious disease, I should say, that a person older than typically 60 years old will have. Now, somebody was telling me earlier, well, people don't know that males can get UTIs. Males can get UTIs too. Now, but it's more common to see it on females, okay? When I did a search trying to get some facts, there's not enough information out there. I couldn't find the right information to talk to you about on the web. I did a search on the web. I went to the medical portions that are not free, and there is not enough information. I'm a certified medical director for long-term care means that I am a member of the National Society of Post-Acute and Long-Term Care. That's nursing homes, assisted livings. I'm currently a medical director of 2 nursing homes in town. And we love for you guys to know, because a few years ago, if you come to the doctor with bacteria in your urine, you will get an antibiotic. And what does that do? Resistance. It increases the resistance of the antibiotics. As it is today, we're talking about the medication crisis, how expensive everything is, but do you know that there is no new antibiotics on the pipeline? It's very expensive to develop an antibiotic, and the ones we have the bacteria are developing resistance faster than we develop new antibiotics. Years ago, when penicillin came in, that was a wonderful thing. Everything was cured with penicillin. Now, we barely use it. Okay, then what I did is I wanted to educate you a little bit about UTI, and then I would like you to ask me questions and we can start talking about a little bit more in depth, okay? Any questions so far? No? UTI is basically a urinary tract infection, okay? It could be anywhere from your urethra, which is where the urine come out, all the way to the kidneys, which they call the pyelonephritis, okay? Which the higher it goes, the more severe the infection is going to be, okay? Now, if you look at it, it's one of the most common infectious diseases in older people. It's basically 10% in women and 5.3%. Basically, half of the males get UTIs in regards to women. That's basically what that is. Why are people older than 65 more vulnerable to bladder infections? Well, you get older, your immune system gets weakened. That's why you get vaccines to prevent infections. You know, almost every major vaccine for adulthood starts at 65. Once you turn 65, if you haven't had it, you need to get all those beautiful vaccines that your doctors recommend. Okay? A lot of people lose cognition when we get older. Therefore, our care is not as good as it was when you were younger. There's also limitations, physical limitations. Arthritis is very common. And ladies probably can understand this a little bit better than males. Hygiene with arthritis in your hands and your shoulders is not the same as when you were 20 years old. It's more difficult. Then even so you try, it's still not 100%, okay? There's also other health conditions, diabetes, coronary artery disease, congestive heart failure, things that have nothing to do with the heart, but limits your ability, make your muscles weaker. Therefore, it will limit your ability to take care of yourself overall. And that, of course, increases the likelihood of developing a urinary tract infection. Drinking water. Most people don't drink enough water. I have patients tell me they don't like water. It's like, well, if you don't like water, it's hard. 70% of your body is water, and you don't like yourself. Now, I like cartoons. My son always makes me put cartoons when I'm doing one of these. But this cartoon actually has some important information. Diabetes is very, very common, right? Diabetes also will increase your likelihood of developing urinary tract infection, because when you get diabetes, your immune system does not work properly for multiple reasons, multiple, but the most important one is you start losing little proteins through your urine, and we don't see it. Those are called microproteins. Those microproteins are part of our immune system, the immune globulins. And we lose those, we are becoming immune deficiency by definition. And that makes, on top of that, if you put sugar in an area, you always get ants and all these other little things coming, right? In the body, it's the same thing. The bacteria like sugar. They develop in sugar-rich environments. Now, what are the classical symptoms of a urinary tract infection? Basically, I'll show you the other ones, but I want you to focus first on the mental signs. What can happen when a person older than 65 develop a urinary tract infection? Confusion, disorientation, agitation, dizziness, falling. Falling is one of the biggest things that we have. A lot of the time when people get to the emergency room, the first thing they do is the urine. Well, I just fell. Why did you fall? Are you having a bladder infection? It's one of the most common diagnosis after a fall to have a urinary tract infection. And it's not because the infection came in after. It's most likely the infection triggered the fall. Also, what happens when people has a fall? Broken bones. This is very common. Then don't fall. Okay, well, is a pull back on the muscle? The muscles on the back, or is the urinary tract infection? We don't know. It's very confusing. It's one of the most straightforward diagnoses. You have a bladder infection, but it's also one of the most difficult things to diagnose if you don't think about it. Now, a lot of the times we get patients that come to the office and say, well, you may have a bladder infection, but I'm not sure. Let's get a urine. The urine comes with cloudy, dirty looking, but lack certain parameters. Then so let's look at the culture. And then we get a culture. The culture comes with 50,000 bacteria. 100 is the colonies, is our cutoff. But it comes with 50,000. Then you're really not sure. Well, now we're sure. That is not a urinary tract infection. It is very normal, especially on women, mainly on women, to have bacteria in the urine without having a bladder infection. Then if your doctor tells you you do not need an antibiotic at this time, please believe them. Don't force them to give you an antibiotic because it's not going to help you. It's not going to do anything. Okay, keep that in mind. Now, when we use chronic catheters, when we use other devices that are on the bladder, that increases the risk of developing a bladder infection, but also increases the amount of bacteria that are living in that bladder. Therefore, we have to be very, very careful because, again, we're running out of antibiotics. We don't want to use them if we really don't have to. And there is a lot of clinical guidelines. There is a lot of things that we have to we look into. There's blood, there's no blood, there's nitrates, there is leukocytes, there is sediments, a lot of other things that we look from that little urinary test that we do. I always tell the patients, I'm gonna wait until it all depends on but when I see this bacteria, I say, I'm gonna wait until the culture comes. Well, but I need something now. You may not need it, and I wanna know because we have used so many antibiotics throughout the years that I may give you something that doesn't help you because the bacteria is already resistant to that antibiotic. Therefore, what I'm going to do is I'm going to create you another problem, which we can talk in the future about that. It's called C. difficile colitis. That's something that you probably have here before. That's straight related to the antibiotics and the immune system coming down. Then that's something that we'd like to prevent while treating the bladder infections. We'll talk about that. If a person is having a lot of cognitive problems, having debilities, having falls, having issues, we need to balance. There is criteria that we use at the nursing homes and in clinical practice of when to pick an antibiotic. I'm going to ask you a question. What do you think is the most important treatment for a bladder infection? Anybody? Water. Somebody asked me if beer is okay, and I said, well, that's fine, you can pee, that's okay. But drink some water with the beer as well. All right, this is the most common, this is the classical signs of urinary tract infections. Basically fever, frequency or urgency, burning, that's what dysuria means, tenderness on the upper part of the pelvis area, or pain in this area here, that's our costovertebral tenderness. Now, that is the book. If my patients come like that, I don't have to worry about, I know what it is. I will tell you that only 5 to 10% of people have those signs. Then, this is the book. Medicine, there is a reason why they call practicing medicine. This disease is the same on everybody, but the outcomes are different on everybody, because the person, you are an individual. We have 5 fingers in each hand, and none of them are equal. And that's what the dilemma comes, okay? I hope you remember those symptoms with this little cartoon here. All right. Now, when we have a positive culture, we have, if we have more than 2 pathogens, we always say it's a contamination. You may not need the antibiotic. It's very hard to have more than 2. Most likely you only get 1, but 2 can be present. And again, if you hit a certain amount of number, we always try to get 1 antibiotic that hit both, but because of the amount of antibiotic resistance nowadays, sometimes we have to use 2 antibiotics. Now, as people age, we all lose the ability to fight infections. Then get vaccinated, drink a lot of water, do the best you can, and hopefully we'll avoid these problems, okay? Now, before we get to the questions, we're gonna talk a little bit more about dementia and UTI. Does anybody here has had a family member with dementia? Okay, that's what I thought. Have you, any one of you have had this family member with dementia and also having a urinary tract infection? Anybody willing to share what their experience was? Right?
Several years ago, and she was demented, and all of a sudden her behaviors changed, and I had to fight to have a urine done, and they did it, and they would not treat her because her temperature was 99, and then I had to go and fight with the doctor and say, you've got her on Tylenol 4 times a day for pain. She's not going to spike to your parameter because you're keeping the temperature down with the Tylenol. And they treated her with the antibiotic, and within 24 hours she was back to her usual self.
That's a very good point. A lot of the times, and that's one of the things that Chris was saying, I like to hear what the family member or the caregiver have to tell me. To me, it's actually more important than what the patient itself is telling me. Because when you have a urinary tract infection, the brain doesn't function properly. Why the brain doesn't function properly? Because the chemicals that our body release with the infection, lactic acid, a lot of the end products, will get to the brain through the bloodstream. Our cells in the brain work in membranes. There is different membranes, like one of those water arrow systems that we have in our homes. And the chemicals have to move from one membrane to another. And the concentrations in between, that's what give us our either depression, anxiety, or we spike our behaviors, depending on certain areas of the brain. As you can imagine, if your membranes are becoming bigger, because that's usually what happens, not thinner, but becoming bigger in the sense that it's difficult to cross, difficult to maintain those concentrations of chemicals in proper range or in balance, basically, because we have to have a balance. Then that's when the behaviors start. That's the reason we develop behaviors, because our brain, number one, is not working properly. That's the number one thing. Why? Because the concentrations are not there. On top of that, now we're changing the environment. We're adding more chemicals that are not supposed to be there. Basically poisons. It's all end products. The body's fighting, it's killing bacteria. It's dumping all these end products of the destruction and metabolism to the environment that these neurons have to work on. Then that's why you have to pay very close attention. And when we see behavior changes, the first thing we do is not think about urinary tract infection. We think about what else is happening. Is there pain? Is there hungry? Are they been eating? But then the fourth one is they having a urinary tract infection. Why? Because if they have not been eating, we should know about that. We take care of them. If they have not been drinking, we should know about that. Those are things that we can rule out in less than a minute, for the most part. And then we go into the bladder infection. Now, I'm not expecting a person with dementia to be able to tell me all those beautiful classical signs of bladder infection. As I told you before, that's the book. That's what we go to the school and we learn. But that's, there is a medical books and medical life. Medicine is different than what the books are. The books are basically a guideline. Very good point what you just mentioned. A patient that the first thing I do, I tell them to, in my practice, at the nursing home say, do not give any Tylenol, do not give any ibuprofen. I want to know what happened. I want to give her a couple of hours. Get the urine. I want that urine collected as soon as possible. But I don't want to mask any of the other symptoms. Like, I guess that was the problem on your mom. Because obviously she was 99. She was spiking. It's just, yeah, she was spiking. But again, a lot of the times it's the environment. A lot of the times we get the phone call from the family or the nurse. But the nurse fails to tell me the patient's taking Tylenol, or the family fails to tell me that. Then that's one of the things that we have to be more detective. Is dementia, making a diagnosis of any source, bladder infection, pneumonia, in a person with dementia is actually more difficult than in a pediatric. I didn't went into pediatrics because I thought it was going to be difficult. This is definitely more difficult. But then those are the things. Basically, people change their behavior. And they can become aggressive. Not because they're mean. Well, some people are mean, but that's not the case. But it's basically because their reality is different than your reality. I always tell you, if you want to know what a dementia person feel like, plug your ears with cotton balls, get glasses that don't belong to you, put it on, tape your one leg to the other, and try to function. That's how they feel. They don't see well, they don't hear well, they have when we get dementia, we have difficulties on our motor skills. Imagine if we are compensating with whatever left we have of our brain, and suddenly I dump a lot of poisons into that brain. That's what we get. Anybody else have any other experience that would like to share with us?
I actually had a caregiver but delusional. I'd like to make that a point about being so delusional. And is that the severe end of it?
No, it's not the severe end of it. It could be. When you have dementia, you can be delusional because, again, your reality is different than the reality of a demented person. They are seeing things that you may not be seeing. Why? Because it's the chemicals imbalance that we were talking about. Remember, dementia, there's different kind of dementia, but if you get vascular dementia, for example, tissue die. There's no tissue left. There's scars. Then that function that was there is not there anymore. That's one problem. If you get Alzheimer's, you get something called tangles. That is these fibers that wrap pretty much around the neurons and kill them. And then what you have is this amount of tangles in that brain. That area is not working either. Then there's other areas that are going to potentiate. the best example I have is when you have somebody who is born blind, their tactile and their hearing sensations are great. We all know people like that. When people don't hear well, they actually can read your lips. They can see things that they are not. The end of is that when you have a deficiency, you're going to compensate with other areas, but then those areas then are going to start reacting to the external stimuli. You may be the helper, but they don't see you as a helper anymore. They may see visions. They may see, especially if you have a lot of different cultures. Okay, that is in certain cultures the death has a lot of importance. There is a lot of coming back from death, the spirits and all that. That can exacerbate when you have dementia, because those are your beliefs. That's the things that you learn from when you're a child. And remember, most of the dementia comes in this way. You start as a child, you develop, you come to the culprit, and then you start regressing. It's almost the same way. It's very easy to know on patients that are bilingual. I mean, if I get dementia, that's probably going to happen to me. You are born with one language, use it for half of your life, and then learn a second language, and you can communicate, you can do okay, but then when you get in the dementia, you hit that point, you're going to start forgetting that second language, and you're going to get to your first language, and eventually you're going to forget how to speak, because that's how Alzheimer's basically works. Then illusions, hallucinations are very common. You get patients with Parkinson's disease, which have a lot of motor problems already. They develop dementia and they start having hallucinations. I have a couple of Parkinson patients. Ladies, don't get mad to your husbands if they have Parkinson, because the number one hallucination or delusion and is basically that the wife is cheating on the husband. This is a classical. And it's typically not real. Now, they have all their hallucinations, and Parkinson's is very interesting. Most of the Parkinson patients, when they start having these hallucinations of, that was a delusion, but the hallucinations is visual. They can see little kids playing around. That's very common. They are actually pleasant hallucinations. They are not the threatening hallucinations. Okay? When you get patients with alcoholism, that's how the brain works. You get either dementia from alcohol or you get withdrawal from alcohol. We have had patients when I used to do the hospital that came in through the emergency room in withdrawal from alcohol because they have been drinking for 20 years and suddenly they had decided, God, I'm going to stop. Or most common is because they run out of money and couldn't buy the alcohol. But anyway, then you put them on the IV, you start giving the medications, the vitamins and all that, and they start seeing snakes coming out of their hands. Those are the IV lines. Then they have to be, somebody was telling me that we should have dementia units and not to tie the patient. That patient, we have to tie it because they will rip all the IVs out and then you have no medications, and that's very dangerous. People die from that. Okay? Then the brain is a very complex, and I believe we have a neurology later today, right, Amy? We do.
I want to say 11:30.
At 11:30. They will be able to give you way more information than I can in how the brain works. But I try to put it as simple as possible. Your chemistry is the fuel that your brain engines work with. When you change the concentration of fluids, your brain's not going to work properly. Then that's why you get delusions, you get hallucinations, you get behaviors, you can get aggression. And a lot of my patients tell me, or the family members, like, I've been telling her that there's nothing behind this door. There's nothing here. It's just a decoration. And I always tell them, why are you spending the time and wasting the time telling them that? If they want to believe that there is a door, there's something behind that door, it's okay. It's okay. Don't aggravate yourself. Don't let them aggravate. Wait until they get a little bit better, and then once they have a little bit better understanding, tell them, okay, go and open the door. Oh, there's no knob. Yes, it's just a decoration. Oh, okay. But the next day, they may go back and tell you the same thing. That's okay. The caregiver burnout is a very important thing. We all suffer from that. When we have to take care of somebody, it doesn't matter what age, I can tell you that. Even if you're young, full of energy, you're taking care of a demented person or a disabled person, autism, Down syndrome, any of those. It's very challenging because there's different levels of function. Therefore, you need to, the way I tell my brother is like, you know, because he lived closer to my mother, it's like, you know, just pick your fights. Don't fight about everything. Just pick your fight. It is dangerous that this is a decoration door and there's nothing behind here. It's not dangerous. She's not gonna go through that door anyways, then I don't care. I worry more about the front door. That I wanna lock. I wanna make sure that she's not able to open that door, okay? Those are the things that we have to work. Okay, I don't wanna eat today. Okay, you don't wanna eat today, that's okay. Tomorrow, I know you like soup. I'm gonna try to make you soup that day, even so if I have to change my menu that I already have planned. Because eating is a very important thing, especially when you're getting older and older and older. You're starting to forget to eat, to drink, and it's a lot of physiology behind that too, when dementia. The brain is shutting down, basically. Then we have to help on nutrition. But also when it gets so advanced that there is really no return, and do we have hospice coming too at some point?
Part 3.
In part 3.
April 27th.
27. That will be important because then a lot of the times when hospice, when we reach to the end and I tell the families, you know, really, there's something else we can do for your family member, is to help them through the end stage. And we decide to call hospice, we look at the risk benefits and all that. A lot of the things that hospice tell patients, family members is, it's okay, don't want to eat, that's fine. And you have to learn, again, pick your fight. Do the best you can while the person is functional, and then help them through the process. But the caregiver is a very, very important person in the life of this resident. And a lot of the times, caregivers doesn't have to be just the family member. You know, you have the assisted living, we have the nursing homes. They do a great job, even so I know if you look at the TV advertisement that there are dangers, people die and all that. It happens, people die in certain environments, certain areas. But for the most part, the people that are working there, they want to take care of the patients, okay? And then we need to help them. If we have a family member there, we need to help them, and they will help you as well, because it's a very difficult thing to do. There's a reason why the resident has to go to an assisted living or a nursing home. It's because they will have, we hope that they will get better care than the one we can give them. But we still need to be part of that. Okay? Now, any other questions?
You are very proactive about not doing the antibiotics, checking everything beforehand, doing this, doing that. What do you do if you have a doctor?
What do you do if you have a doctor who jumps on the antibiotics? Even before the test is done. Oh, my husband was in the hospital, and they took him off his dementia medicine, and then 3 days later, he started acting agitated. Well, duh, come on. And so, he's agitated, he must have a UTI. And they popped him on antibiotics right away. And the next day, the test came back, he didn't have a UTI, and they wanted to continue the antibiotics. And I said no. And we're no longer with that doctor, but do most doctors, and this is, you don't have to answer if you don't want to, but do most doctors, UTI, antibiotics, this is the path we're taking? Or is your way of thinking, to me it's much better, it's more logical, it's better for the patient, but is this a new way of thinking, or?
I would like to tell you that my way is the right way.
I think it is, but I vote.
But the reality is, not every doctor, it all depends on, there's multiple things that you go through when a doctor goes for training. It all depends where they train at, who trained them, who they train with. If I'm gonna train in Miami, in a hospital located at South Miami. South Miami is a younger, thriving community. The Cleveland Clinic in Weston, we all talk about the Cleveland Clinic. Oh my God, the Cleveland Clinic is amazing, this and that. It's a younger professionals, fairly wealthy, or mid-class, thriving community. Most of your patients in that environment are going to be younger people, are going to be people who has other problems, and your mind will be shaped in that setting. Now, that doesn't mean that you should behave that way. There is guidelines. Now, I can tell you, I'm not a geriatrician by training. I'm internal medicine. What is a geriatrician by training is basically somebody who goes 1 extra year to apply internal medicine to the older people. I did it through my training. We have a mixture of, I will say, 70% of older people and 30% of younger people. Then we had all that. Then I moved here, and for the last 15 years, most of my patients, I will say, what's in the probably like what, 85%? 85% of my residents, of my patients are in my office are older than 65, and 99.9% of my nursing home residents are older than 65. These are the guidelines. I just took my board. We have to take it every 10 years. I retook them 4 years ago. That is the board. That is the test. That wasn't the test. When to treat, and specifically that I remember that question. Bacteria in the urine, leukocyte positive. The person had 1 day of confusion. The urine was collected. It came back because you get the report right away, but the culture takes 3 days most of the time. Then when you read through, the answers were, you have to pick the answer. You treat now, you wait, you refer, or you send to the hospital. And the answer is you wait. If you get somebody with a lot of infection, with a good bladder infection, now we're not talking about pyelonephritis, with fever, with white count elevation, that's a little bit more complex. But just like the burning, the discomfort, if I cannot do anything else to you, I can put an IV on you and give you 2 liters of fluid and make you pee, you can wait 2 days. Most of the time, you will be able to wait 2 days because you're flushing that out, okay? There is a reason why I would tell the patient, there is a reason why the kidneys are here and you pee through here, because it has to flush out. Then when you flush out those chemicals, you're getting rid of bacteria. They have done a trial. I look at a lot of the trials. I look at information that comes from the hospital. I'm going through my recertification for medical director now as well, and then I keep reading. You have to keep reading. Now, do I know everything? No, I don't. Nobody knows. If somebody tells you they know everything, it's not true. But you have to do the best you can. Do I make mistakes? Yeah, I have made mistakes in my life. And I probably make more. Important is to know, to learn about those mistakes, how to apply it, read about it. If I don't know something, I go and read about it. The older generation physicians, which are great, has a lot of experience, but they were trained into treat, antibiotics. The new way is not to give antibiotics. There is a government Medicare-sponsored program, and the state revised. The nursing homes, by the way, if you didn't know this, they are, every single year, there is a survey team of 10 people that come and review everything, from quality engagement to what you do. Do you give antibiotics in somebody who didn't need it? That is a problem. they discount points to your credits from that. Then in certain way, I'm forced to think this way. There is something called for Medicare, this is antibiotic stewardship. It's just not to use antibiotics for reasons that they are not clearly stable. There is bare criteria that you have to follow. Again, that doesn't take a place of the human-to-human contact. You know, I'm looking at the patient, I know what the problem is. I have a nurse who's looking at the patient telling me that I know what she's trained to look at. Then that basically nothing can change that. But the fact, to answer you, if there is a new way, no, it's not a new way. I think it's the right way. Go ahead.
Is there a way to treat a UTI without antibiotics?
If you have a cystitis, which is I'll consider a urinary tract infection as well, because the bladder is inflamed because the bacteria was there, you can actually treat it with fluids. You can give antiseptics on the bladder. Everybody's aware of the azo and things like that. The azo comes in a prescription strength that we can use. It all depends on the comorbidities. For example, if I have a 25-year-old lady, sexually active, that went for her wedding, came back and things like, having a bladder infection, I can probably treat her, just drink a lot of fluids, maybe get a couple of vitamin C's and this and that, and we can probably get rid of that without any major problems. Now, I have a 59 or a 65-year-old lady with diabetes. That's a different story. That is a different story. It's the same disease, different generations, okay? Then it is very difficult to say yes or no to the right treatment will be 3 days of antibiotics. You don't have to do 7 days. For the most part nowadays, depending on the culture and the numbers that the lab report, we can pick 7 days, 5 days, or 3 days, depending on the sensitivity of the bacteria to the antibiotic we're using.
Have you used there's a new test out there called the DNA urine ID. Have you used that?
I have used it in 2 occasions. Not actually, I have interpreted, not used it. I didn't order it.
Okay.
It's a very good It's a very good test. It's very expensive. That's the problem. It's very expensive. It doesn't change the way I'm gonna treat. If I have a positive bladder infection by my nitrates, my gold standard still is the culture. Now, that will help me, but that will take a week to come back. Most of the time. I know they tell you that it comes sooner. It doesn't. They don't do it in Florida. They have to ship it to California, at least the ones that I have seen. Then I'm not gonna delay. If I really, really know, or if I really suspect that there is an infection, I'm not gonna wait for that test to come back, But again, some insurance don't pay for it. I know my insurance doesn't pay for it. I had one done for a different reason in a family member that has my same insurance, and that test was not covered. Then you have to be aware. I'm not gonna order, that's another part. I'm gonna try to order things that I know you're gonna be able to get done because it's cost prohibitive now. I think eventually that will be the first line of care, but I don't think it is right now.
I'm so sorry. We're running really far behind on our time, so I apologize. I'm sure Dr. Ruana would love to talk to you guys. He'll be around. But I would love for you guys to give Dr. Ruana a round of applause for his wonderful presentation. We do thank you so much. And again, I'm sure he's going to be around to answer any more questions. I would like to introduce you guys to Rob Harris, who is here with the Alzheimer's Association. He's the program director for the Memory Mobile. So he's going to tell you a little bit about that and what you can get done here today.
Well, thanks for having us here. I travel 16 counties with that 40-foot RV. We try to go to rural areas and do outreach, education, and programs to bring people aware of what the disease is and what the association can do for you. You come out and see me in between the breaks and lunch and stuff like that. I'll be here until about 2:30. I can get you any information you might need for here in Charlotte County. So feel free to come on out and take a tour and see what it's all about. Thanks.
Good morning, everybody. You got the two purple people. I'm Amy Schenk from the Alzheimer's Association. I am the program manager. I'm actually based in our Bonita Springs office, but I do have a fun fact about my connection with Charlotte County. Okay? Now, I know it may shock you, but I actually am the women's gold medalist in the 50-meter dash in the Charlotte Senior Games. Okay? Now, I forgot my medal. Now, that may sound kind of exciting to you, and I want it to because I get to go to the state senior games, so I'm really excited. And my daughter said to me, well, that's good, Mom. And then I told her I was the only one in the event in my age group, and it kind of tarnished things. So I'm still really excited. Aside, I'm really slow. I've never run track and field in my life, but I figure, what the heck, I'm gonna do it. So you're reigning gold medalist for Charlotte County. Okay, that's not why we're here. You got some wonderful information earlier on, and I have, and actually Rob has these on the memory mobile, the basics of Alzheimer's disease. So we love it when you take our stuff. So I have some of those on the back table, and we also have some on the memory mobile. And I think we touched on what it's like to be a caregiver and how hard that is. So I also have a handout that talks about 10 ways to manage caregiver stress. It would be wonderful if we could get rid of all of the stress in our life. But you know what? If you turn on the TV or you drive in Southwest Florida, I don't know about you, but I seem to have a lot of stress. So we're going to get started today, and what we're going to talk about is understanding Alzheimer's and dementia. Now, I bet you didn't think that I was going to make you work, but I am. So let's see if I can use the clicker. Now, we could listen to that music forever, but I don't know about you. I'm kind of over it after the first couple. Okay, here we go. I need technical help. I always need technical help. The magic is happening. Don't you love technology that's smarter than you? Because heaven knows I do. And it's a good thing I have teenagers because they explain to me how ridiculous I am. Like, Mom, it's so easy. Well, clearly it's not easy, so don't let your kids tell you that. So, here's some of the things we're gonna do today, and I'm gonna switch my hands here. Didn't know I was gonna be two-fisted. Usually I have a cup of coffee in one of these hands, so. Let the magic work. It's not gonna work.
I'll have the next one. You tell me more.
You know what? Let me do that. So we're gonna do this in a creative way. I'm gonna walk around because I can make that happen. Show me how to. Okay. So here's what you're gonna learn today. And the good news is there's no test. So what we want to be able to do is we want you to understand the difference between Alzheimer's and dementia. Know how Alzheimer's disease impacts the brain. We talked a little bit about earlier on how infection and how delirium and how some of the changes that happen as a result of that can occur. And usually those things come on suddenly. With dementia and Alzheimer's disease, it's a slower progression, and sometimes that can be kind of a clue for you what's going on. We're going to touch on the risk factors. We're going to go through the 3 stages. There are currently some approved treatments to help with symptoms. So we'll touch on those. And we're also going to talk a little bit about what's going on in research, and then also share with you, and I'm going to give you the best secret, the best resource the Alzheimer's Association has, and it is not me. So, although I am a resource, we have a wonderful resource for all of you. So, I told you, you didn't know that you were going to get to be quizzed today. But hey, it's Saturday and it's the morning, and if I'm going to work on a Saturday, I want you to work too. So, let's see what question comes up. Okay, now I'm going to also tell you something. The 2019 statistics just came out, and this slide is already outdated. So how many think, we're going to look at how many Americans are currently living with the disease. How many say 850,000? 5.7 million. Any takers? Okay. 12 million. 3.4 million. I'm sorry, there's no prize for the winners here. Actually, it's 5.8 million. So 5.7. What we do is we look at our information and we update it every year. So 5.8 million. Okay, you're right, I'm wrong. How many unpaid caregivers? All right, now we know there's a heck of a lot of them, right? So 1.2 million, 8.5 million, 13 million? How about 16.1 million? 16.1 million. I need Rob to do the slides, please. And you're wonderful, and the reason I say that is because we came up with a wonderful new presentation. It's different than the old one, and it has all these little tricks, and it's not intuitive. So notice, thank you so much for your help, but Rob knows his presentation a little more. I figured you wouldn't. For Pete's sakes, I'm gonna make him work too. Here are the facts. Once every 65 seconds, somebody develops the disease. So think about it, if we talk for an hour, what that impact is. So another little test that isn't in here, but I just like to do a poll. How many of you remember, and I call it back in the olden days because I graduated from nursing school in 1980. Sit on that for a second. How many of you remember hardening of the arteries? Look at this. How many of you remember senility? How about just old age? Just people, old age. And you know what happens when you get old? Your mind goes. Well, we know that's not true because when I graduated from nursing school, we thought all of those things actually, that's what we knew. And we also know that in 1980, Jerome Stone started, it was a family group that started the Alzheimer's Association. So we've learned a lot in a short period of time. So, is it part of the normal aging process? Are we all destined? How many people think, yep, it's just gonna happen? How about no? And that's one of the things that we've learned, and that's a significant change from 40 years ago. So, this is just an old people's disease. People younger than 65 don't get it, do they?
Yeah.
They do? You're exactly right. We think probably the youngest known person that I've cared for in their 40s. 40s is, and certainly I think we'd all agree that's pretty darn young. So whenever someone has the disease, there are things and concerns that we think about. The concerns are a little different when someone is 45 and maybe they're still in the workforce, or they may have children at home.
Dementia is the
Can you see that we just say like haven't gotten in sync here? So what we're going to do, actually, please go back, Rob.
Dementia is the umbrella term for an individual's changes in memory, thinking, or reasoning. There are many possible causes of dementia, and Alzheimer's is the most common cause. Other causes of dementia are vascular dementia, which is marked by changes in the blood flow and the blood vessels in the brain. Dementia with Lewy bodies, identified by specific brain changes throughout the brain that include the buildup of a protein known as alpha-synuclein. And frontal temporal dementia, which is marked by brain cell loss in the front sections of the brain or the frontal lobe. Each type of dementia may have distinct characteristics to cause specific behaviors in the individual, but there is also some overlap in behaviors among the types of dementia.
One of the things we get questions about a lot is, well, you know what, it's not Alzheimer's disease, I just have dementia. You just saw in the picture really that what's the difference between Alzheimer's and dementia? So dementia is the broad category, there are different types. And I like to think of it, it's like cancer. Cancer is a collection of symptoms. That's the heading, but we know there's breast cancer, and there's testicular cancer, and there's colon cancer, and there's lung cancer. So we think of dementia is that collection of symptoms, and there are different types. Alzheimer's disease is typically the largest type. So why is it important to get an early diagnosis? Because I'll tell you, I get people say to me, Amy, there's no cure, and I don't want to know. Why might somebody want to know?
Certainly having the diagnosis of Lewy body was helpful in our planning because we began to understand where this was coming from in the brain, where otherwise we would not have known. Like we knew something was happening, but what was it? To give it a label actually helped, although it was a big umbrella. You know, it explains some of the characteristics and symptoms that we were experiencing and seeing.
Well, I think we all want to know that. One of the things I like to say is, don't guess. How many of you remember that commercial on TV? It was a Holiday Inn Express, and the guy says, well, I'm not a doctor, but I slept at a Holiday Inn Express last night, right? We think we're experts. Unless we are a physician or healthcare provider and we can do all of our own diagnostic testing, you know what? It's better to leave that to the experts. We want to know, and we want to have credible information. So here's kind of a summary of what we talked about. It's not a part of normal aging, and I think that's one of the things that has changed significantly since I got out of nursing school in the 80s. So what is it? What's Alzheimer's disease? What is it? Let's talk a little more about it.
More than 100 years ago, Dr. Alice Alzheimer described specific changes in the brain, what we call the formation of plaques and tangles. Now, Alzheimer's is a progressive brain disease that's marked by these key changes and is thought to impact memory, thinking, and behavior. The brain has three main parts: the cerebrum, the cerebellum, and the brainstem. Each one plays a role in how the body functions. The cerebrum fills up most of your skull. It is part of the brain most involved in remembering, problem solving, thinking, and even feelings. There are about 100 billion nerve cells, or neurons, throughout the brain that transmit messages in order for us to create memories, feelings, and thoughts. Alzheimer's disease causes nerve cells to die, which leads to the brain tissue loss, or what we call shrinkage, and causes loss of function and communication between cells. These changes can cause the symptoms of Alzheimer's disease, such as memory loss, problems with thinking, planning, behavioral issues, and even at the end stages, problems with swallowing.
So here's one of the things that I get a lot. Many of us think of Alzheimer's disease and we think of it as memory loss. Our brain is kind of mission control for our body. It controls everything. So we talked about planning, thinking, emotions, communication. Every action that we take really the brain is responsible for. So it's not just memory problems when somebody has Alzheimer's disease. This is a great question. I get this all the time. So what's the biggest risk factor? And I think I get to quiz you on this one too. Okay, let's see who. I wish I had prizes. It'd be more fun if we had prizes. So, what's the greatest risk factor, known risk factor for Alzheimer's disease? How many people say genetics? How many people say family history? How many people say age? Well, Rob, did you go back to the winner? The winner is, it's age. As we get older, all of those things are there some they're potentially contributing factors, but as we get older, we have a higher risk of developing it. And a lot of times people say to me, well, Amy, I don't remember all of this Alzheimer's talk, all of this, years ago. Well, one of the reasons is, as I said, I got out of nursing school in 1980. I rarely cared for people in their 80s, much less 90s, or someone who was 100. And today that's much more common. I mean, we thought, in our infinite wisdom when we're 20-year-olds that all those 60-year-old people were old, and clearly that's not true, right? So we didn't care for that many. I just didn't take care of that many people, so that's one of the things we've seen. So let's hear from our expert.
Alzheimer's disease is marked by specific brain changes that result in the clinical changes in individual experiences. That is, changes in memory, thinking, or reasoning. And ultimately, Alzheimer's is fatal. The exact cause for these changes is unknown, but there are some hints as to what may contribute to an individual's risk. Age is the greatest known risk factor for Alzheimer's. And when we look at populations of people, we see an increased risk over the age of 65. However, Alzheimer's is not normal aging. Family history is also a known risk factor. Research has shown that those who have a parent or a sibling with Alzheimer's are more likely to develop the disease, and that risk increases if more than one family member has Alzheimer's. When we talk about the genes involved in Alzheimer's, there are two categories that could potentially be involved: risk genes and deterministic genes. Risk genes increases an individual's risk for developing the disease, but does not guarantee that they will develop Alzheimer's. Deterministic genes, which are rare for Alzheimer's, guarantee that the person will develop the disease.
So here's what it is. Age, and we all want to age, but we want to age in a healthy way, don't we? Because the opposite of aging is not aging, and I think we're all here because we want to continue to age and be healthy. Family history is a risk factor. I like what Dr. Snyder says, the difference between a risk gene and a deterministic gene. So things can run in families. Heart disease seems to run in families. Diabetes seems to run in families. Alzheimer's, again, there can be that familial connection. A deterministic gene means if you have the gene, you'll have the condition. So that's the difference. And individuals with Hispanic descent as well as African Americans have a higher incidence of the disease. So Dr. Snyder's going to walk us through the different stages of Alzheimer's disease. We look at it at three major stages. For the purpose of simplicity, early, middle, and late. The thing that's important to know is that there are different symptoms, and people can have symptoms of one particular stage. It's not an exact science. It isn't as though everybody fits into each bucket. So you know what?
One of the things that
Go ahead.
impacts our brain is all the other things that can happen to us as we age. And we know that Alzheimer's, the most common risk factor for getting Alzheimer's disease is age. But we also have lots of other things that go wrong with us as we age. And so how those other health factors impact our brain can also impact how Alzheimer's presents in other people.
You know what, Rob, could you just choose on a different kind of forgetting? Because one of the things we think about is, well, I forget. How many of us forget things all the time? Okay, so here's the different type, and it can kind of give you a little bit different perspective. Go ahead.
It really, really is. It's not just forgetting where I put my car keys. It's much deeper than that. And for example, I cannot read a book. I used to be a voracious reader because by the time I turn a page, I had forgotten what I had read. And if you're reading a novel, you have to know what transpired before it in order for you to continue to read on. And so I can't read a novel, so I've even stopped trying.
More experts.
Alzheimer's affects everyone differently. As a result, it's difficult to place a person in a specific stage of the disease. However, there are 3 general stages that are commonly referred to as early, middle, and late stage Alzheimer's. In a medical context, you may hear these stages referred to as mild, moderate, and severe. In the early stage of Alzheimer's, an individual may be able to function independently. However, they may start noticing more frequent memory lapses.
I didn't mean to do that. Just trying to.
Memory or concentration by conducting a detailed medical interview. Middle stage Alzheimer's is typically the longest stage and can last for many years. Damage to the brain cells can make it difficult to express thoughts and perform routine tasks, and this can lead to increased feelings of frustration and anger. In the final stage of the disease, an individual loses the ability to hold a conversation, control their movements, or respond to the environment around them. Cognitive skills, that is their memory, thinking, and reasoning skills, continue to decline, and this can lead to personality changes and need for round-the-clock care.
Key point here, everybody's different. Not everyone experiences the disease the same way. We're all individuals, we all have different underlying health issues, so that's really one of the key takeaways. It's a trick question. This is a trick question. True or false? There are several drugs available to slow down the progression of Alzheimer's disease. How many of you say that's true? How many of you say that's false? Rob, what one is it? It's false. There is no treatment that prevents or changes what we call the progression of the disease. Now, medications, we're going to talk about it a little bit more. Medications can improve symptoms, and it's important to know that medications work for some people. We're all different. Some medications work for a period of time, so it's a very unique situation. But the medications that are approved are not what we call disease modifying. And what disease modifying means, it changes the course of the disease. So we'll talk a little more about that. Go ahead, Rob.
There are currently several drugs that are FDA approved to treat the cognitive symptoms associated with Alzheimer's disease. They treat the symptoms, but they don't treat the underlying cause. So eventually people will progress, but they do treat some of the symptoms and help people for a time. So the first class of drugs are cholinesterase inhibitors. These drugs work to prevent the breakdown of acetylcholine, which is a chemical messenger found in the brain that's associated with learning and memory. There are 3 FDA-approved drugs that are in this class of drugs. There's Aricept, there's Exelon, and there's Razodine. There's another class of drugs that modulates glutamate, which is another chemical messenger in the brain that's associated with learning and memory. And this drug is called Namenda. And then there's a final class, which is actually a combination of cholinesterase inhibitors and glutamate modulator. And this is called Nazar.
So I think this is a misconception. Now, does that mean that Medications may not, you shouldn't try medication, absolutely not. What it means is that it's symptomatic relief. It doesn't necessarily, it's not gonna change the course of the disease, but absolutely, in consultation with your physician or their healthcare practitioner, you wanna see if that's the right decision for you. So let's touch on research, because people say to me, well, what do you mean there's nothing that can stop the disease? Research, when you think about it, even though Dr. Alzheimer identified those changes in the brain in 1903, a long time ago, my grandmother was born then, I had to do the math, she would be 116 years old. Our disease really is a younger disease. We talked about the Alzheimer's Association starting in the 80s. So I never learned about that in nursing school. It wasn't that long ago, it was the 1970s. So research and looking and trying to figure out what the heck makes these changes happen in the brain is critical. Why don't you hit early intervention, please?
This is an incredibly exciting time in Alzheimer's and dementia research. The advancements that we've made in the last decade to understand the disease as a continuum, meaning that the biological changes are starting a decade or more before someone is experiencing the changes in the memory and thinking. This sets the stage for possible prevention. The idea that when we have the tools to identify those individuals at the earliest time point, and when we have the interventions to target individuals at that earliest time point, we can intervene to stop or slow the progression of the disease before an individual loses their memories.
So before we touch on lifestyle factors, I have heard many times, people will say to me, you know what, my mother was just diagnosed with Alzheimer's disease, but you know what, Amy, when I look back, I know that there were some changes that were going on sooner, and that's what we're finding. The changes in the brain happen long before their symptoms. And so that may be a key to trying to figure out how to intervene, how to change the progression of the disease. But by the time we're seeing those symptoms, the disease has taken hold.
I'm excited about what we're learning these days regarding lifestyle. One of those things that we've seen in the past of things like exercise and nutrition have now started to gain more momentum to indicate to us that it can change your ability to slow cognitive decline. That is really the first stages of Alzheimer's disease. This may include things like social engagement, mental cognitive training. It can be things such as exercise, it can be nutrition. All those things are now starting to point that they will lower your risk for Alzheimer's disease.
So before we jump into anything else, one of the things, how many of you have heard, we know what's good for our heart. February was National Heart Month. It's all the exciting things like exercise and diet and not smoking and managing our blood pressure. And so the thing I like to tell you that if it's good for your heart, it's gonna be good for your brain. But here's the exciting thing. We believe that there is some connection with lifestyle and this disease. But you know what, just because we think it's there, we think it's there. The Alzheimer's Association is currently funding one of the gold standard type trials, which is called a prospective randomized double-blind placebo-controlled clinical trial. Okay, mouthful. And actually it is looking at the impact of specific lifestyle interventions to be able to see and hopefully find out and to be able to say with confidence, if you run the 50-meter dash, it's gonna help you. I'm kidding, but I hope so. We started enrolling participants in Wake Forest. It's actually gonna be, there will be 3 clinical trial sites. Wake Forest, there will be a location to be determined in the Midwest in the greater Chicagoland area where our home office is. And then we're also gonna be enrolling individuals in California. So this is really exciting. It's called the US Pointer Study. And I'm enthusiastic because we've been saying, if you're doing that good lifestyle stuff, wouldn't we all like to know that there are things within our control that we can modify? So it does take a long time from enrolling people and going through the study and then analyzing the results and all of that. That's a very long process, but it's also very hopeful.
A lot of hope does come from the Alzheimer's Association, all the research that is being done. Even though there is not a cure today for the disease, I know in my heart there is going to be a cure one day. And I know we're getting closer for that cure. Because even if you fail in a research study, you learn from that failure in the research study. That failure always brings progression.
I think one of the things that I didn't know when I joined the association, the Alzheimer's Association is the largest non-governmental funder of research to find a cure for Alzheimer's disease.
It's more important than ever for people to participate in clinical studies. The fact is, right now, we don't have an effective treatment to stop Alzheimer's disease. And if we don't have people participating in clinical trials, we never will. And so participating in a clinical study is one way that everyone can get involved in a very direct way in the fight against Alzheimer's disease. And for people who currently have dementia or Alzheimer's disease, there are some additional benefits. You get access to very close medical care. You also may be among the first people to have access to the treatments that will eventually prove to work.
Sometimes you hear the phrase, it's a failed trial. That means that it didn't hit the endpoint, it didn't achieve an FDA-approved drug. But I would say as a scientist, the only failed trial is one that doesn't give you valuable information. And if the trial is well designed, if it is a good scientific experiment, you get extremely valuable data so that you can plan the next trial and do the next study even better than the last one. And it gets you that much closer to that FDA-approved drug, to that effective treatment, and maybe someday even a cure.
That's exactly what I think. Sometimes we only look at it as a glass half empty. Every time we learn what doesn't work, we're closer to getting to what does work. So when I heard this in this perspective, I looked at things a little bit differently. Because just like anything else in life, we need to know what isn't going to work. So I like the optimistic approach. There's no such thing as a failed clinical trial, with the caveat that it was a well thought out, well designed trial. We're getting close. We're getting close. The Amy and Rob show, we're gonna have to practice, aren't we? That's the first time we've done this, clearly. So, but let's talk about what resources there are for you or for other family members. This is the purpling of America. The only reason I really love that slide is, of course, I like purple, clearly, but we are available nationwide. We have the best resource. So I told you I was going to tell you my best resource. So before I let you learn a little more about it, it is our 24/7 helpline. It is available 24/7, holidays, you name it. Issues don't happen Monday through Friday from 9 to 5. And why I love the helpline is that we have dementia experts who are trained to answer the call. So I mentioned to you that I work from the Bonita Springs office. I haven't been in the Bonita Springs office, I was in the Bonita Springs office Tuesday because I'm on the road and covering a lot of areas and doing education just like this. So our helpline is always available. And here's a couple ways people can use the helpline so I can kind of show you the whole continuum. Maybe you'd like to know if there's a support group in your community. You don't know where to call? You can call the helpline. It's not a critical need, but it's an important need, wouldn't you agree? What about in Saturday morning at 3 in the morning, and you're a caregiver for your dad, and you wake up and you go into Dad's room, and Dad's not there. and you look all around the house and you can't find Dad. And you look, and you know what? The back door's open. That's a crisis. Our helpline can help with that too. Certainly one of the things that you would want to call the helpline first. There's some things to do, but you're going to be pretty upset and anxious and concerned to have a plan. The helpline can deal with those issues too. And the beauty of the helpline is that after you've had an opportunity to speak to one of our care consultants, they will probably say, Rob, you know what, would you like would you like me to have the local representative follow up with you? And Rob can say, no, you know, I'm good. Maybe I just needed to know where the support group was. But if Rob was in the scenario where his stress level was here, and our helpline will help kind of manage through that, he may say, oh my gosh, please, could you do that? And through the wonders of technology, somehow that call gets into what I have a vision that like hops into my call queue. I can see that Rob needs me to call. I know what's going on, so what I can do is I can prepare before I call him, so I don't have to say, so Rob, what are we talking about today? Like, isn't that annoying anyway? Don't you love it when you have to tell your story 5,342 times? No, I can look at that and I can say, wow, Rob's dad got out, here's what the concern is, so that I do my research and I kind of know where Rob lives, so I can at least be available and be a support for him so that I'm more prepared. I love the helpline. So you can do the helpline. Click on the helpline.
I've had a couple of phone calls that I've been able to make in to the call center when I've had a couple of quick questions that I wanted to ask. You know, there's been a couple of nights, 2 o'clock in the morning, you have questions, you have anxieties, and I was struggling dealing with them, and it's amazing. It was one of the best things I ever did was keeping the call center on my favorites now. Just to know that there's somebody you can call who is aware of what you're going through.
Go next. We also have tons of information online. It is like, I call it an information tsunami. So usually what I like to do is after I've spoken with someone and we really know what area that information they're interested in, I can send that via email. It's a little bit easier because I could get lost in our website. I could be on our website learning new things for at least a week. So I know, and I want to make sure I'm really respectful of our time here. I'm going to be available for a while. I'm happy to answer questions, but Rob is here, and you have to have noticed the green, orange, purple bus. I mean, you can't miss the bus. That's the bus. That's our mobile office, called the Memory Mobile, but we have information, resources, all kinds of things. And Rob is going to be here for the entire session today, so if you have questions, he's happy to help. And I'm happy to do that too, but I want to make sure we're getting on with the agenda. And I don't know what's next, so. Well, thank you.
I appreciate it. Thank you so much. And if you guys have more questions for, did you already go over this? About the,
I already did.
Oh, you did? All right, good, awesome. So you guys obviously saw that big old bus out there. So a lot of great information they have. If you have any other questions, please feel free to reach out to them. We're going to get prepared for our next speakers. They are neurologists in town. And then what we're going to do is, as soon as they get done, we're going to wrap up and go ahead and go into lunch. Not wrap up completely. We have a great program this afternoon, but at least go ahead and we'll make sure that you guys have lunch. We got food, drinks, all that great stuff, and then we'll continue on with this afternoon's program from and get you guys out of here around 2 o'clock. Okay. With our next speakers, what we're going to do is, if you guys have questions, instead of doing it up here, we're going to have time where you guys can go and meet with them one-on-one. You know, so whether that be during lunch or if you have time that you can connect with them, you know, sometime after that, and you guys can have a little bit more of a private conversation. So we'll make sure that you guys have time for that as well, okay? All right, so we'll go ahead and welcome Dr. Nazar, and his beautiful wife, Dr. Evans. So 2 neurologists. There you go.
Hi everyone, my name is Dr. Nazar, this is Dr. Evans. We're here, local neurologists here. I just came here about a year ago, so we're new to the area. We both did our neurology residency here at Larkin Hospital in Miami. We're also both fellowship trained in headache and facial pain. We're boarded in neurology and psychiatry in the American Osteopathic Association, as well as the American Board of Neurology and Psychiatry, and also board certified in headache and facial pain. So we're here to shed some light about Alzheimer's dementia. I know Amy did a really great job about covering everything really broadly, but of course we're here to answer some more questions and kind of go more specific with kind of the effects of the brain here, okay?
So it's very nice to be here. I'm Dr. Evans, and again, we practice in Port Charlotte across from Fawcett Hospital. So, if you ever have any questions or need to see a neurologist, we'd be happy to see anyone. And again, we're here to talk about Alzheimer's dementia. Alzheimer's dementia is the most common dementia we know in the United States. And when we think about the dementia and how it affects the brain, it affects, the entire brain. And when we think about the brain in general, we think about the different parts of the brain. We think about our frontal lobe, that that's the part of the brain that's responsible for how we're executively functioning, about how we're doing our things, making our judgment, and also in how we're planning and having all of our issues with, doing things around the house, as well as coming up with our financial planning, as well as billing and doing things that you normally would do. And when we also think about dementia, we're thinking about areas of the brain responsible for memory. And most of that is going to be in your temporal area, and that's going to be responsible for a lot of the memory issues that we're going to see. And that's going to be required more with the short-term memory loss, and more with, questioning and answering things as people will ask repetitive short-term questions. And we're also going to think about, too, with the parietal lobe, that's also going to be responsible for a lot of our executive functioning, as well as getting out and asking and remembering short-term details around your, with your family, as also remembering details, with dates of birth of your family members, and remembering things you also used to, remember in the past. We also think about, in that specific area, you might have difficulties with, remembering people's faces. That's also something that might happen at the beginning or at the end as disease progresses. And you're also going to remember and have difficulties with, forgetting things, as well as sometimes we'll have difficulties with writing. And that could be something that could begin at the beginning of the disease, or as well as at the end of the disease. And then also with this, we're also going to notice some difficulties with, executive function that's going to happen, as well as problems with your visual spatial, and that can be responsible for difficulties with driving, as well as getting lost. That's a common thing that you're going to see as well as the disease progresses into the milder to moderate stages. I'll let you talk a little bit.
So, I think really we gotta recognize when a patient has dementia. I think it really comes down to the caretakers, the family members, the people that the patients really interact with. Because I think a lot of our patients that we see, they really don't know they have memory problems. I think that's the first thing that we see actually. When they present, they come in with, my family member has some memory issues, but they say, no, I'm totally fine. And that's something that we really have to keep as, as caretakers of our family members, to keep an eye on that. And that's something that we need to bring these, let them see the primary care physician, bring them in to see a neurologist, get an examination, get an assessment, because sometimes the changes that happen in the brain, like Dr. Evans mentioned, the frontal lobes, the parietal lobes, the occipital lobes, all these areas can be affected by dementia. There's a lot of different types of dementia, but specifically Alzheimer's dementia, but typically it's the temporal lobes and shrinkage there that causes memory issues. So I think really having a very good understanding of what to look for, and like Dr. Evans mentioned, changes in behavior is one of the big things. Changes in short-term memory is a big one as well. It's not always just memory. I think Amy mentioned that during her lecture. It's not always just memory. That's something that we kind of put in synonymous with dementia and memory, memory loss. But also changes in behavior, changes in mood, agitation, aggressiveness, things that maybe your family members just not acting typically how they are. Something that's changed. Usually that's what we hear. Sorry about that. Yeah. So these are things that we need to kind of monitor and look for in our family members. Okay. Again, the dementia, and broadly, different types of dementia. There are, typically it's the pathology of it is different protein accumulation within the brain. We look at tau protein, beta amyloid protein. These are kind of normal proteins that, can you hear me? These are kind of normal proteins that kind of misfold abnormally within the brain, and that kind of causes a lot of accumulation of this disease process of amyloid, beta amyloid, as well as tau fibrillations in the brain. So there's a lot of new research trying to, either measure these amyloid proteins, measure these tau proteins, get rid of these amyloid and tau proteins, but right now there's nothing really FDA approved for that. Right now there are medications, I think Amy mentions a few of them, donepezil, which is Aricept, and Namenda, memantine, Exelon patch. These are kind of things that we use on a pretty regular basis to help people with mild to moderate, like with Aricept, and moderate to severe with memantine or Namenda, to help kind of slow the progression down. And how that works is really affecting the neurotransmitters within the brain. So there are things that we can do that we want to recognize that these people have memory problems early on to help kind of assess that and treat those issues versus waiting for it to come to a moderate to severe stage where it's a little bit, the progression is already there and these medications are just less effective. So that's why it's really important as a caretaker to keep a close eye on your family members, kind of monitor for these kind of changes. Again, it's not always dementia. I think Dr. Romano talked about UTI, infection, things that mimic dementia, things that look like Alzheimer's dementia. That's why it's really important to bring your family member in to get assessed, because we want to make sure it's not something else going on. And those things, that's what we look for. And I'll answer questions in the end, okay? So that's the things that we look for in patients, that if there is any kind of secondary cause of these issues. So, and these are common things that infection, other things are sleep apnea, problems breathing, other cardiovascular issues. So we want to look at the whole picture, but at the same time, we want to, again, look at other things that are causing dementia, and that's a big workup in itself, but there are things that we can do to help kind of slow the progression down at this point. I'll let Dr. Evans.
Okay. Like he had said, with our brain, it's very complex. And when dementia does come, we do notice that our neurons, which are responsible for transmitting our signals in our brain, they are affected by this disease. And like you had said, the amyloid plaques are formations that come, and they do build up in the brain more than what we notice with a normal, aging brain. And those plaques are going to show up in the area of really, more in your memory center at the beginning, but then they can also affect the rest of your brain, including, your temporal and parietal lobes like we had talked about, as well as the tau protein. That's another major protein that we do notice is affected by the dementia process, specifically the Alzheimer's disease. The tau is responsible for keeping your neurons, in area of helping get the neurons to transmit the signals in your brain. And really, when that comes and is affected, it's going to affect your neuron, and that's why the neuron's not going to fire as well as what it probably could, after going along with, normal, aging process. And with a lot of the research that's going on now, they're trying to target those specific areas with the amyloid and the tau protein. And hopefully in the future we'll have something that's going to prevent this disease, and we'll try to stay very positive with that. And again, when we think about this, we also think about how it's going to affect this and some of the oxidative stress that goes along in the brain. They've shown, with some of this that, the memory loss can come, that can be affected also ultimately by oxidative stress and some of the research. And that's why we look at a healthy lifestyle and a healthy diet. And right now, they're recommending in the research, I'm currently recommending a Mediterranean diet. A diet low in carbohydrates that's really good, with fish, lean meats, and also a lot of vegetables, fresh fruits, and, avoiding carbohydrates in limit. And also, we're also trying to, prevent, a lot of the, secondary risk factors that can come along with it. Proper blood pressure control, and always talking to your doctor about keeping your blood pressure less than 140/90 is an important factor. We also like to keep, proper things, keeping your cholesterol is a very important thing to talk to your doctor about. Pre-diabetes is also a very important thing. We always want to control our diabetes, because that can also increase the risk of these, proteins, these plaques, these tangles that come, that can increase the risk of that coming, and also increase the risk of the oxidative stress in your brain. I'll let you talk a little bit.
Yeah, I think, we get kind of bombarded with all these supplements on TV. You watch TV, it's like Prevagen, all these other vitamins. I tell my patients, really, they mentioned a study in Prevagen that, is effective. None of these medicines are FDA approved, unfortunately, for dementia. I mean, I tell patients that, it's okay to have some supplementation of vitamins. There is some research on vitamin E as being effective, but really, there's nothing conclusive for supplementation of vitamins. Sometimes vitamin deficiency can cause memory loss or problems with thinking. We check like B12 levels, folate levels, but I'm not telling patients to start these without knowing what their levels are, first being assessed, because sometimes you can get toxicity of vitamins, it's a possibility as well. So I always tell my patients to be careful, be mindful. I don't want them to destroy their pocketbook with buying all these different types of supplements that are touted as being regenerative for memory loss. But at the same time, we do check some vitamin levels and we try to see if there is some kind of deficiency in that, because if there is deficiency in like thiamine, which can cause memory loss, or which is vitamin B1, or B12, which can be very useful for neurons to basically synapse with each other. If there are these kind of vitamin deficiencies, then we want to know and we want to treat those things. But again, there needs to be more research, and there is research going on about these kind of supplementations. I just want to touch base on that. I think that's a really common question that I get from my patients here. Another thing I think is really important is, being active. I think that's something that comes up a lot. Having good interaction with family members, having good conversations, being out and about versus staying at home and not really doing much at home. I think that's really important for the mind. Studies have been done to show that even having, a better reserve, knowing the second language, learning, increasing language ability is really important. So, I tell patients always, be active, read, don't watch TV, don't be a couch potato. It's not going to help you. It's important to kind of be active in your mind and be social too. Interaction with other people is very important. Talking with other people, having conversations, using your language ability. Just like I like to compare sometimes the brain is not a muscle, but comparing to a muscle that, if you don't use it, you're going to lose it. So if you just stay at home and do nothing and you kind of vegetate, it's not going to be better, even though sometimes it's difficult to have a family member to come out. And that's why places like this is really helpful. Supervised environment, places where they can interact, places where they can kind of stimulate their mind, because there are a lot of studies that are coming out to show that stimulation of the mind is protective for the brain. It helps, we don't know if it's regenerative at this point, but it is very protective. And, like Dr. Evans mentioned, a healthy diet, reducing risk factors, as well as being active, exercise, 30 minutes a day. We look at that a lot as well. These are very important points to kind of look at.
Yep. So as the disease progresses, at the beginning stages towards the moderate stage, there can be some confusion that does occur. And again, this can happen, as time goes on. And again, more as we notice with the patient, it's going to be more occurring more, as maybe the nighttime happens. And sometimes this is called sundowning, where confusion can happen, and people will not notice exactly where they're at. And they also might notice that they're becoming more confused, having difficulties with sleeping. And again, that's an important factor in, keeping a healthy, environment. Always, trying to keep yourself awake during the day, and also trying to sleep at night like you normally would, as you were younger, or, as time has gone on. And we recommend that, important factors into this, we also want to make sure that we're not dealing with any type of, urinary infection, or if something would happen, we want to rule out some type of infection. If you'd ever notice that, someone's getting more confused, we want to rule that out acutely. We also, recommend that keeping yourself, awake during the day and having a good type of, having something to do during the day helps stimulate your brain. Also keeps, yourself from having less confusion that does occur during the day. And also trying to get as much sleep as possible. And sometimes sleep problems can happen. And again, that's normally, when you want to talk to your doctor about trying healthy lifestyles, and we can also talk about medication, for that. But again, that's also a very important part. Sleep is very important for our brain to help heal it, as well as help us think the next day. And so keeping yourself awake during the day and sleeping at night is a very important part, and preventing some of this confusion that you're going to notice that can occur as the disease progresses. And also, with this too, we also want to, make sure that we're also keeping ourselves active as much as we can, at least trying to do some type of, aerobic exercise, at least walking, or going out and, being involved in some type of, social environment through some type of, supervised exercise program. And also, with this, we also want to make sure that if you think the confusion is happening every day and it's becoming debilitating, that you really talk to your doctor, because there are things that we can do to help, control that, and also, help, keep yourself, as comfortable as possible for that. You talk a little bit now?
Sure. So, again, things for patients that have memory loss, when she touched base on a lot of these things, having good routines is important, having kind of a regular schedule, when they know when to wake up, when they know when to have dinner. Sometimes even people with moderate to severe memory loss can forget to eat. So it can be kind of a very destructive and even at the end stages fatal process. And I think Amy touched on that as well. So, having a specific routine, a specific schedule is very important. Being understanding and managing medications. I love the pill box. I think that's very helpful for these patients. Having a good environment, regular exercise, good sleep schedule. Again, so that can sometimes be a very big challenge, because sometimes when we see our memory loss patients have a really irregular sleep schedule, either sleeping during the day, being awake at night. She mentioned the sundowning, which happens, which is basically confusion. A lot of times as the disease process progresses, the lobes, like Dr. Evans mentioned, we have different types of lobes, parietal lobe for awareness and visual spatial. These areas are all atrophied and have shrinkage and damage. So sometimes being disoriented can be a big issue. So some severe disorientation, that's a lot worse when they're in different environments. So sometimes when it becomes dark, they can be very disoriented, very confused, hence the sundowning effect. Also with hospitalization, also with infection, that can also worsen symptoms. So even with a urinary tract infection, something that's very simple and can be treated quite easily, can cause pretty disastrous effects in someone's mental status, confusion, irritation, agitation. So these are things that we kind of want to watch for, monitor, and hopefully put them in a good rhythm of schedule to help treat these things. So I think a lot of things that we see as well in our patients that we treat for dementia, it's going to be a lot of times caretaker burnout, these kind of things as well. So that can be very difficult. It can put a lot of stress not only on the patient who's going through a pretty severe chronic disabling degenerative brain disease, but also the family members around them who have to deal with the secondary effects of that, which are going to be problems, social problems, problems with financial issues. So these are things that we also want to kind of keep in mind and have understanding. That's why it's important to kind of look in the beginning and see if we can kind of try to adjust our schedule slowly versus an abrupt change. Because sometimes when they get to us, it's quite far gone. There's a lot of different changes that are going on. Maybe it was missed earlier, maybe we just didn't recognize it in the family. So having the treatment early, even with these medications that are out now, like the donepezil and memantine and all these other combination of medications, they come in different combinations, can help kind of slow the progression down. But again, I always counsel that it doesn't stop the progression. This is a degenerative disorder, unfortunately. But again, there is a light at the end of the tunnel. I do believe that there's a lot of research coming out, and a lot of research trials that are coming out that are going to be more effective. And I feel like we're learning a lot more about the brain. I think if you look back in the history, 50, 100 years ago, I don't think we knew anything as near as what we know now. So I think there is something that's going to be in the future, looking at the amyloid plaques, looking at measuring these amyloid plaques, different brain scans to kind of see the prognosis and the change that's going to happen over time. So, any questions, really quick? Maybe one or two, and then we'll go. Is that okay?
Yeah. So you want to do like 2 questions?
Let's do 2 questions, and then we'll move. I know you raised your hand a while ago.
Well, okay. Thank you for presenting. I appreciate your time. My question is, do you have any suggestions for family members that are recognizing that their loved one is exhibiting these symptoms, about getting the patient into the doctor? Because what I found with personal experience and professional experience, I'm caring for my grandparents with dementia, sundowners, working as a caregiver for many years, that was my biggest challenge, was getting them into the doctor. How do you, when they don't want to?
You know, that's a really good question because I see that really commonly. And when they do come see me, they're not happy to see me. I don't see them smile. But I'm like, don't worry, I'm here to help you, okay? But I think the biggest thing really is going to be to, in the beginning, I think the primary care physician is really important. I think that's kind of the hub of everything. You know, when they come up to me and they didn't touch base with their primary care, then I think the thing is they have a relationship with their primary care physician. You know, this is a doc that they've been seen for years, you know, for 5 or 10 years. They've seen them change over time. So, you know, they say, hey, Jeff, you know, this is different. You look different. You know, we saw each other last year. Things have changed. What do you think? You know, they may say, no, I'm fine. But then I think having that suggestion, you know, I know this doctor, he's a neurologist, or, you know, he's able to kind of talk about what's going on. I think that kind of relationship is really important because when I get those consultations out of the blue that, didn't go through the primary care, the family's really worried, they just went out to the neurologist, then the patient's really, there's a lot of resistance, unfortunately. There's a lot of resistance, a lot of kind of almost anger sometimes too, because they feel like, oh, you're betraying me. You know, this is something, you know, why are you want to put me away or something like that. And I think that's something that we do not want to show to them. That's not the reason. We need to help them. We need to get them feeling better. I hope that was helpful. Yeah. You had a question? Go ahead.
I was told that,
everyone here.
I was told that my dad would refuse to wear his hearing aid in both ears, and then a lot of the time he wouldn't wear them at all. And I was told that can have a big effect on accelerating dementia, and I just kind of wondered if you agreed and what you had to say.
You know, and so if you can't hear, you know, a lot of how you're going to be, you know, speaking and communicating with people, that can be like a big thing that we always check. That's one of my number one things. I want to make sure that that's, you know, kind of ruled out. We want to make sure that you're able to hear, you know, function normally. If you're not able to hear, you're not going to be able to communicate directly with the rest of the, you know, the people around you. And that's something we always check. You want to make sure that they're hearing effectively before, you know, we say that that's not a, you know, component of it. You know, you might get more confused if you're not able to hear people around you and also, you know, communicate effectively with you. And so that's something I also recommend, that they wear their hearing aids and that the hearing is checked at the initial appointment. That's one of my major questions I always ask all my patients.
Yeah, I definitely agree. I think that having a good communication, being able to verbalize and understand, I mean, it's, you know, you can make a parallel to the infant. You know, when we check infant, I'm not a pediatrician, by the way, so you know, but when you check infants, we always do a hearing test because sometimes, you know, if that's missed, it can be thought as learning disability because they just can't communicate. It's the same thing with older people. You know, if they can't hear, if they can't communicate, you know, are you dozing off? No, they just can't hear you. So I think that's a big issue.
But does it reduce, does it have to do with illness? Does it reduce your ability to think well?
So having hearing loss doesn't necessarily reduce, or people that have hearing loss don't have a connection of like dementia, I don't know if that's your question, or of Alzheimer's disease. There is the pathophysiology of hearing loss, depending on the cause of it. Really, it not necessarily, I mean, if you do have a hearing is kind of interesting because there's a lot of crosses throughout the brain. So it's very difficult to have something called central hearing loss, which means damage within the brain that causes hearing loss, because if it crosses so many times throughout the brainstem, which is the bottom of the brain. Most hearing loss is within the inner ear or within the 8th cranial nerve, which is the nerve to the ear. So if there is a stroke in the temporal lobe, I'm sorry, I'm going kind of specific, but there's a stroke within the temporal lobe within the brain itself that can cause memory problems and cause hearing loss at the same time, possibly. But typically we don't see that. Most of the time it's a peripheral hearing problem. So it's kind of unrelated. I think the hearing issues come to more of the fact that the patient can't communicate well, can't hear well, maybe becomes disinterested in things, maybe, you know, that's probably more likely the scenario with that, okay? And I think we're gonna cut off now, but if you have any other questions, please feel free. We're gonna be in the back and we'll be happy to answer any, okay? All right.
Thank you so much, guys, for coming. And again, if you guys have other questions for our neurologist, please feel free to reach out to them in the back. And you guys can ask those questions privately, and you guys can have that intimate conversation about what's going on in your guys' life. Before we start, they're getting lunch ready for you guys. So we're gonna get that ready here in a second. I just wanted to let you know what's going on next Saturday, what we're gonna be doing, and then also what's happening the rest of this afternoon. So this afternoon, we're gonna be talking about medical nutrition therapy, and we're also gonna be talking about Parkinson's disease. And Project Lifesaver, Tammy Wilkie with the Charlotte County Sheriff's Office is going to be speaking about Project Lifesaver. So those are going to be the 3 topics that we finish the day with. But then next week, we're going into organizing legal affairs and making a financial plan. And so this is a very important step. You know, once we have kind of established that there's, and first of all, kudos to you guys for being here today and taking a proactive step in learning about what's going on with your loved one, or just even trying to figure out how can I, you know, what do I do next? Where am I supposed to start? What am I supposed to do next? How does this work? So kudos to you guys for being a part of that. And so next week we're going to talk about that from a financial and a legal perspective, what you could do, and how you can make, you know, and how you can make that legal plan for your loved one so that it'll work for them, it'll work for you, and you can help them get the care they need. And of course, April 30th or April 27th, we're going to be going over the different types of care, everything from, you know, adult family care homes to assisted living, independent living, skilled nursing facilities, hospice. There's just so many different, you know, terms out there that you guys probably are just not familiar with, and we want to help familiarize you with those services, and then make sure that you know how to find them in the area. So thank you again so much for being here. We're going to do it buffet style, I think, right? So just wanted to give a shout out to Jeffrey Tomas. He's from the Modern Woodman, which is he's a financial advisor for Modern Woodman, and they provided the lunch for today. So just want to give a shout out to him as a thank you. And we'll get started here with lunch. We'll wrap up at about 12:30. We're going to start back, and we'll have, we're going to be talking with Christiana. She's going to be talking about medical nutrition therapy. So if you have to use the restroom, if you have any questions, make sure you ask our neurologists that are here. Go check out the Memory I can't say it. I've been tongue twisted. But anyways, go check out the Alzheimer's bus outside. And if you guys have any questions or that for me or anyone else here, just if we have a CPT on, come find us and we'll help you guys out, okay? Thanks so much.
Why does there have to be? Because Joe said so? No, because it would make sense. I don't know. How would that make sense?
Probably the best compliment for you, everyone else.